How are you?
When initially diagnosed, type 2 diabetes is mildly
I
progressive. One can
remember.
achieve good results with just diet and
Uh,
exercise, and by doing so, I can set patients up
we don't
for
have CD.
success.
You have a report?
Well, I think that this is a myth, because
Report
diet and
maybe in your
exercise
mobile
alone,
check.
despite being
CD, we don't have CD
essential
drive.
part of diabetes treatment, can hardly achieve good and sustained results by themselves in the vast majority of
Mhm.
cases. In fact, less than
What happened?
25% of the patients treated so can maintain a good glycemic control
Infection?
and intensively improve it. And we
Any
have to
paper?
take
You
in
have
mind
paper?
also that
Any
many of these
doctor
patients
prescription?
haven't been
Anything?
struggling with obesity years before diabetes onset. So it doesn't really seem easy for them to follow this
Mm-hmm.
lifestyle
Mm-hmm.
treatment.
Mm-hmm.
Well, to be
Okay.
sure that it is really important to offer patients advice regarding healthy lifestyle habits. But I would say that even more important is to offer patients efficient tools like early pharmacological interventions that for sure will help them achieving weight and glycemic targets, and above all, will ensure a tight, early, and sustained glycemic control. A UK PDS study showed that an early pharmacological intervention, regardless of the drug class used, as compared to lifestyle modification as the unique therapy, resulted in a better initial glycemic control that was associated to better microvascular outcomes. Additionally, this on the long term can confer a metabolic legacy effect based upon these differences in HbA1c attained during the first years of diabetes. This would translate into a reduced micro and also macrovascular risk of events that has lasted through years, even in the case of higher HbA1c values.
Okay, then now breathing, yeah. Now open, system open. Finish?
HbA1c targets below
Not finish. Okay.
7% are generally recommended by most guidelines. So having patients close to that
You
number
can
is
go,
enough to
sister.
keep
I'm
type
coming.
2 diabetes
You
under
can go,
control
sister.
and
Then I will
prevent
open and
its
check.
progression.
Your mobile. Your
Well,
mobile.
this is
Mobile.
clearly a myth because it
This one
represents
we
the
don't
usual
have CD.
dilemma
You
between
can give counter.
suboptimal control
They can
and
open. Your
treatment
mobile.
intensification as one of the phases
This
of
is yours.
therapeutic inertia. Such approach,
Okay. Okay.
especially at the beginning of the disease, places patients at a higher risk for worsening of glycemia in shorter periods of time and at increased risk for micro and macrovascular complications on the long run. Well, the Discover study is a good example of how delayed treatment intensification causes missed opportunities for early glycemic control and its related benefits. In this study, we saw how in different parts of the world, initiation of second-line treatment takes way longer than recommended, at occasions up to 4 to close to 7 years after diagnosis, and the average HbA1c is well above 8% before starting this intensification.
He doesn't know English. Okay,
Well,
okay. Then
the
thank you. You're
diabetes in
helping
aging
him.
study represents a
Good, you
recent
are helping
evidence
him.
that supports the metabolic legacy effect that was proposed after the UK PDS trial, but adding an important concept: stringent metabolic control, as low as 6.5% or lower, attained as soon as 1 year after diagnosis, had an independent impact on reducing the 10-year risk for macro and microvascular complications as compared to suboptimal glycemic control.
Obesity is not just rising, it's driving over 200 complications. In 2022, 2.5 billion adults were living with overweight, including 890 million adults with obesity. Acting now could help prevent this number from reaching 1.5 billion by 2035, as projected by the World Obesity Federation. Obesity is often seen as a matter of willpower, when in fact it's a chronic multifactorial disease influenced by socio-cultural, environmental, epigenetic, genetic, biological and behavioural factors. Misunderstanding obesity leads to labelling people as lazy, fueling weight stigma and delaying care. Avoiding or delaying healthcare can cause obesity-related complications to remain undiagnosed, worsen and become increasingly difficult to address. By the time individuals talk to their doctor, 82% already have at least one obesity-related complication. It is well known that obesity-related complications are driven by adipocyte dysfunction. Healthy individuals display normal adipocytes, but in people with overweight or obesity, adipocytes increase in size and number. This contributes to accumulation of lipids in ectopic and visceral fat depots, which can lead to local and systemic inflammation and insulin resistance. Obesity-related complications are highly interconnected, with the presence of one disease increasing the risk of developing another. Let's take a closer look at some of them. Cardiovascular disease complication. Excess adiposity results in neurohormonal dysregulation, increasing the risk of all forms of cardiovascular disease and cardiovascular risk factors. Obesity increases the incidence of myocardial infarction by 2 to 4%, and the risk of heart failure by 5 to 7% with each unit increase in BMI, and each 10 kilogram weight increase is associated with hypertension, with a mean of 3 and 2 millimeters of mercury increase in systolic and diastolic blood pressure, respectively. Obstructive sleep apnea complication. There's a bidirectional relationship between obesity and OSA, and fat deposits in the upper airway and thorax may worsen OSA. 60 to 90% of people with OSA have a BMI of 25 kilograms per square meters or higher. OSA disrupts appetite-regulating hormones and sleep, leading to reduced physical activity, contributing to weight gain and difficulty in losing weight. Metabolic dysfunction-associated steatotic liver disease complication. Excessive accumulation of lipids in the liver triggers several mechanisms that contribute to metabolic dysfunction. 88.7% of patients with metabolic dysfunction-associated steatotic liver disease are also living with overweight or obesity. Polycystic ovary syndrome complication. Approximately 1 in 2 women with PCOS is living with overweight or obesity. A vicious cycle that exacerbates both conditions occurs because PCOS may predispose women to weight gain, and obesity exacerbates PCOS. Type 2 diabetes complication. 90% of adults with type 2 diabetes are living with overweight or obesity. Each 5 kilograms per square meters increase in BMI increases the risk of type 2 diabetes complications, leading to an increased risk of microvascular complications by 21%, kidney disease by 39%, and neuropathy by 12%. Obesity may be complex, but it's also modifiable. Diagnosing and managing it with urgency and achieving weight reduction of more than or equal to 5 to 15% may improve symptoms associated with many obesity-related complications. The more weight lost, the greater the potential benefits. Today, guidelines recommend holistic management plans that are suited to individual needs. Appropriate interventions in combination with lifestyle changes can significantly improve the likelihood of successful long-term weight management. We hope this video has inspired you to start conversations with your patients to enable timely interventions, prevent complications, improve lives, and reshape the future of obesity care. Millions of people with obesity face not only impaired health, but also substantial bias and stigma. 890 million adults were living with obesity worldwide in 2022. Yet studies show that 54% of people with obesity discussed their weight with their healthcare professional in the past 5 years. 36% were diagnosed with obesity, and 21% were offered a follow-up appointment or call after their last scheduled visit. Why does this happen? Obesity is a complex, chronic, progressive and relapsing disease requiring long-term management. So why isn't it treated like one? Often, the answer lies in weight stigma, which stems from the traditional belief that weight can be managed simply by eating less and moving more. However, science tells a different story. Obesity has multifactorial origins, including biological, epigenetic, genetic, environmental, behavioral, and sociocultural factors. Still, people with obesity encounter stigma almost everywhere, with 88% reporting being stigmatized due to their weight. These individuals experience stigma approximately 1 to 6 times per week, which can have severe and lasting physical and psychological consequences. It lowers their confidence to lose weight and increases their risk of depression and anxiety. In addition, it leads to avoidance of physical activity, negatively impacts eating patterns, and increases their risk of health issues such as cardiovascular disease, diabetes, and stroke. Fear of stigmatization has led people with obesity to avoid or delay healthcare. Individuals usually wait 6 years globally and 9 years in the UK before discussing their health with their healthcare professional. By the time they talk to their doctor, 82% already have at least one obesity-related complication. Avoiding or delaying healthcare can cause obesity-related complications to remain undiagnosed, worsen, and become increasingly difficult to address. The good news is that compassionate and non-stigmatizing obesity-related communication can make patients feel more comfortable, so they will ask for help. Even small gestures, such as maintaining eye contact, not avoiding appropriate physical touch, offering appropriate weight management advice when asked, and ensuring equipment fits all body sizes, can help people feel valued, respected, and empowered. Healthcare professionals play a key role in this shift. Creating a supportive environment starts with 3 simple principles: recognize, communicate, listen. Recognize the impact of weight stigma on mental and physical health. Communicate that obesity is a complex chronic disease using respectful, person-first language. And listen. Acknowledge your patient's past experiences with empathy and care. By engaging in proactive and non-stigmatizing conversations, we can pave the way for timely interventions needed for obesity care. Diagnosing and treating it with urgency may prevent or reduce the risk of some obesity-related complications. Multidisciplinary and compassionate care can lead to timely interventions that reduce the impact of these complications. Weight reduction of more than or equal to 5 to 15% may improve or prevent significant obesity-related complications such as hypertension, type 2 diabetes, sleep apnea, metabolic dysfunction-associated steatohepatitis, polycystic ovary syndrome, and more. While appropriate interventions, in combination with lifestyle changes, can significantly improve the likelihood of successful long-term weight management, many eligible adults with overweight and obesity are not being managed with clinical interventions. Updated guidelines now provide clearer recommendations on how to manage obesity. Overcoming weight stigma could be the first step toward better health for people living with this disease. To recap, weight stigma delays care and can stand in the way of timely intervention. By combining compassionate, evidence-based care, we can help people with obesity achieve and sustain better health outcomes.
When initially diagnosed, type 2 diabetes is mild in many cases, so I can achieve good results with just diet and exercise. And by doing so, I can set patients up for success. Well, I think that this is a myth, because diet and exercise alone, despite being for sure an essential part of diabetes treatment, they hardly achieve good and sustained results by themselves in the vast majority of patients. In fact, less than 25% of patients treated so maintain a good glycemic control, even an intensive intervention. And we have to take in mind also that many of these patients have been struggling with obesity years before diabetes onset. So it doesn't really seem easy for them to follow these lifestyle recommendations. Well, for sure that it is really important to offer patients advice regarding healthy lifestyle habits. But I would say that even more important is to offer patients efficient tools like early pharmacological intervention that for sure will help them achieving weight and glycemic targets, and above all, will ensure a tight, early, and sustained glycemic control. The UK PDS study showed that an early pharmacological intervention, regardless of the drug class used, as compared to lifestyle modification as the unique therapy, resulted in a better initial glycemic control that was associated to better microvascular outcomes. Additionally, this on the long term can come from a metabolic legacy effect based upon these differences in HbA1c attained during the first years of diabetes. This would translate into a reduced micro and also macrovascular risk of events that has lasted through years, even in the case of higher HbA1c values. HbA1c targets below 7% are generally recommended by most guidelines. So having patients close to that number is good enough to keep type 2 diabetes under control and prevent its progression. Well, this is clearly a myth because it represents the usual dilemma between suboptimal control and treatment intensification as one of the phases of therapeutic inertia. Such approach, especially at the beginning of the disease, places patients at a higher risk for worsening of glycemia in shorter periods of time and at increased risk for micro and macrovascular complications on the long run. Well, the DISCOVER study is a good example of how delayed treatment intensification causes missed opportunities for early glycemic control and its related benefits. In this study, we saw how in different parts of the world, initiation of second-line treatment takes way longer than recommended, at occasions up to 4 to close to 7 years after diagnosis, and the average HbA1c is well above 8% before starting this intensification. Well, the diabetes and aging study represents a recent evidence that supports the metabolic legacy effect that was proposed after the UK PDS trial, but adding an important concept: stringent metabolic control, as low as 6.5% or lower, attained as soon as 1 year after diagnosis, had an independent impact on reducing the 10-year risk for macro and microvascular complications as compared to suboptimal glycemic control.
best example I'd use is for individuals who suffer with diabetes. We do not wait for them to have nephropathy, retinopathy, or neuropathy before we start treatment. We start treatment early. The minute their fasting glucose jumps beyond the threshold or the A1C becomes higher, we start treating them. And I think this is what we need to do when it comes to obesity. Keep in mind, if I tell you only 5% of individuals walk into your clinic with hypertension are given treatment, you'd be questioning whether you are offering a good service or not. And I think we need to adopt the same model with obesity. And as touched on earlier, there was the element of lack of understanding of this condition and the fact that we believe that it's a matter of willpower, eat less, exercise more. However, we've come to know that nearly all conservative treatments for obesity would fail to sustain their effects on the long term. Similar to what was published even with pharmacotherapies in the SURMOUNT-4 trial, that individuals that stopped taking tirzepatide have regained the weight. And this is what the previous speakers were trying to elaborate on. This is a lifelong therapy. The treatment might change along the way because we're quite fortunate to be living at a time where we're seeing newer molecules being released and being accessible to our patient. And they talked about stigmatization, whether the patient stigmatized themselves, stigmatized each other, or stigmatization from the healthcare professional, and the issue of starting the conversation. I agree with a 5A model. However, part of the other reasons where we were finding it difficult to speak to our patients perhaps is our lack of understanding of this condition. Most of us have not had proper training for the approach, management, or assessment of obesity and associated medical problems. And at one point, perhaps we were feeling as if our hands were tied, where we'd not have treatments or options to discuss with these patients. Not long ago, the only established treatment was bariatric surgery. Nowadays, we're fortunate enough to have the injectables, and soon we'll be hearing more about the tablets. So do your 5As, ask your patient permission, assess them, try to bypass the stigma, and then offer them the treatment tailored to their needs. It is an evolving science. It's an exciting era to be amongst. I could not elaborate more on the importance of early detection and early treatment similar to any medical condition. Ideally, the follow-up should be a lifelong follow-up similar to any other chronic medical condition. I believe this brings my talk to an end, and it is my greatest pleasure to introduce our guest who's joined us all the way from Ireland, who'll be talking to us about, the new kid on the block, if I have to say it this way. So over to you, Michael. Thank you very much.
Thank you very much, Dr. Al-Mamani. I'm really delighted to be here. I've been keeping an eye on the Q&A here. It's fantastic, the questions that are coming in, the engagement from the audience. This is such an opportunity to, I suppose, address so many of the hot topics in obesity. So as mentioned, Mick Crotty is my name. I'm a general practitioner, family medicine doctor by training, but I've transitioned into full-time obesity care, bariatric medicine now, and these are my disclosures. So before we start, I think we have a poll question here for people to answer, and I think this is really, really relevant. The more treatment options that become available, and actually one of the questions in the Q&A was, how do we, choose medications for people? And this is very relevant. Is what is in our practice is the single biggest barrier to treatment for starting or staying on a GLP-1 medication. Is it the injection burden of people taking an injection, even if it's once a week? Is that a barrier for our patients? Is it the safety and side effects of the medication, the cost and access to the medication, or food and timing of medication? So what affects things? Certainly, I would say from my perspective in Ireland, traditionally we haven't had that many options, and they have been all injectable medications, and that is a barrier to many patients, particularly patients maybe who have dexterity issues, severe arthritis, who have needle phobia. Actually, one thing that's not on this poll here would be the storage of medications, refrigeration, particularly if patients are traveling and going to airports, which again, I suppose can be a barrier for some people too. But Dr. Al-Mamani, kind of what do you see kind of in your practice, with patients in UAE as far as kind of what do they report?
I would say probably all of the above, to be honest. The cost is an issue. You talked about the convenience of traveling with it. There's perhaps a misconception that if I inject something, it might affect my body in a different way than if I take tablet, and they believe that the tablet are something more that they're familiar with. So I would say all of the above.
Yeah, and it's interesting to me because I think as healthcare practitioners, sometimes we make judgments based on what we feel our patients kind of would report that, oh, my
Sure.
my older patient may not want an injection, and I make that judgment for them. Whereas actually when we talk to our patients, it's really eye-opening. We may, certainly in Ireland, we may make a decision based on cost of medication. My patient can't afford that, but actually people will come back to us and they will prioritize their health and they will prioritize access to these medications. So I think it's a very relevant discussion, but for me, I suppose the more treatment options that become available, hopefully we are reducing some of these burdens in access to care for our patients. So hopefully people have had the opportunity to answer the question. So where do we see here if we can get some answers from the audience? It looks like it's all 0%, but okay.
Maybe they never got the opportunity. There you go.
Maybe they didn't get the opportunity. But again, I'm sure people find, I suppose, that all of these things can be barriers depending on the patient. But really, it's important that we discuss these with patients as far as kind of what their experience is. So I suppose the great opportunity today is to talk about new treatment options that are becoming available, particularly oral options for our patients, which will potentially remove one of the, some of those significant barriers. We're going to talk about Foundayo or Orforglipron, now approved for obesity care and weight management. So we know this is a once-a-day oral GLP-1 receptor agonist, can be taken without food or water restriction. It's licensed for people with a body mass index greater than 30 or greater than 27 with at least one obesity-related complication. Shouldn't be taken in conjunction with any other GLP-1 medication. As I said, once a day, so convenient for our patients. They don't have to take it fasting. They don't have to restrict food or fluid intake around the time of the tablet. So it's quite simple. And again, many of our patients are already used to taking oral medications, so this will fit very well with their daily schedule. GLP-1, glucagon-like peptide 1, we know this is a naturally occurring hormone produced in our intestinal tract. It communicates with many parts of the body, but around appetite and weight regulation, it's communicating with the subconscious brain, the hypothalamus. And when people take these medications, and our own natural GLP-1 gives signals of fullness, satiety, satisfaction from food, reducing hunger, and potentially changing how our body regulates weight and energy balance. In the periphery, we know the impact it has on blood sugar regulation, on the gut, on our pancreas, and different areas. But the weight regulation portion is predominantly through our subconscious brain. Natural GLP-1 hormone that we produce when we eat probably lasts 30, 60 seconds in our circulation and it's gone. So these pharmacotherapies are modified versions of GLP-1 that will last in our system longer to give more sustained benefits. So Foundayo or Orforglipron, it's a small molecule non-peptide GLP-1, and this is relevant because the small molecule and non-peptide means that it is very well absorbed through the stomach, which has been a challenge with GLP-1 medications in the past. So bioavailability of 77%. So people are taking this medication, it's absorbing very well. Half-life of up to 48 hours. So again, that means we're not getting significant kind of peaks and troughs of the medication, and we can take it as a daily tablet. So again, this is a new thing for us in obesity. And we're going to look at a typical patient that I might meet in clinic or many of the audience might meet in clinic and see how we would consider, treatment for this patient. So as we mentioned, Orforglipron Foundayo, licensed for BMI 27 to 30, with one weight-related comorbidity or greater than 30. And again, this is many of our patients, and traditionally, I think one of the very good questions in the in the Q&A was, why should we be intervening early? And we know obesity is a chronic progressive disease. We learned in previous talks about the set point, this hypothalamic set point, our body defending a higher weight. So if we wait for progressive weight increase, now we are fighting against a stronger current, a stronger stream, that our patient's body, their biology is defending a higher weight. So if we can intervene earlier before they get to the higher weight, potentially the treatment efficacy will be improved, and potentially we will avoid them developing these complications. And, again, we know obesity is a driver of many other chronic diseases, particularly cardiometabolic diseases. So traditionally, we have waited for people to develop these complications and then treated them. If we can treat them early to avoid disease, comorbidities, and potentially have an impact on long-term mortality, that's what we want to do. And, when we have interventions that can achieve this, then we should really be considering it for our patients. So Mariam is a 40-year-old patient. She has a body mass index of 30. She's living with obesity, living with hypertension and high cholesterol. She's a family history of obesity, hypertension, and high cholesterol. Her blood pressure is relatively normal, maybe towards the upper end of normal. She's got an elevated total cholesterol and LDL level. And I think importantly, when it was checked last, her body mass index was 28 the last time it was reviewed. So now it is 30. It has increased over time. We talked to her about her day-to-day. She is very aware of nutrition. She is trying to be physically active. She knows what to do. And again, this mirrors most patients that I meet. Obesity is not a lack of knowledge about nutrition, movement, sleep, stress, good health behaviors. Our patients know this. The challenge with obesity is implementing those health behaviors consistently long-term in the context of our environment, the world we live in, the competing challenges we have, but also in the context of our genetics and our biology. Where many of our patients are predisposed to obesity, they may have dysregulation of appetite, they may have hyperactive reward pathways, they may have many factors, and we learned from the previous presentation of things that can contribute to somebody's risk of obesity. So this would be a very typical patient I would meet in general practice. And, again, I suppose our barometer for considering overweight and obesity is changing because the general population is changing. But in this patient, I think what I would kind of zone in on is the trajectory of weight increase, her family history. She now has a body mass index of 30, and she has early signs of metabolic disease and hyperlipidemia. She is aware of nutrition and movement and sleep and stress and is focusing on those things, but yet her weight is trending upwards. And this just reinforces this fact that kind of over time, obesity is a chronic, progressive, complex disease. It is not due to a lack of willpower and motivation. Most of our patients, and I think for me, it's one thing, I think we misunderstand. All of our patients, irrespective of their weight, size, or health, we should all be focusing on healthy eating. We should all be focusing on physical activity. We should all be focusing on sleep and stress and behavioral interventions. They are a non-negotiable for every person for health. And, if we are focusing on those things, but not seeing the response we need as far as our weight or obesity, then we should be considering next level of interventions. And those interventions, whether it's pharmacotherapy, bariatric surgery, they do not replace the need to focus on health behaviors. They actually support it because they're treating one of the major barriers our patients have in their biology. And if we treat the biology, people know what to do, and it's better, they're easier and better able to implement those health behaviors. So again, typical patient we would see, and somebody who I would definitely be reviewing their history, reviewing their day-to-day nutrition, movement, sleep, stress, behavioral interventions, but also then bringing up a conversation, asking permission to talk about other treatment options and seeing how they feel about it. So we're going to delve into the ATTAIN-1 clinical trial looking at Foundayo or Forglipiron. So this is a 72-week trial, multi-arm, randomized, placebo-controlled phase 3 trial with over 3,000 patients, all over the age of 18, and again, consistent with the licensing BMI greater than 30 or greater than 27 with a comorbidity. And it looked at different dose regimens. So starting off at low dose titration, 0.8, 2.5, and then up to a dose of 5.5 in one arm, 9 milligrams in another arm, and the maximum dose 17.2 milligrams, and comparing that to placebo. So in the study, if we look at, and again, I think a very good question in the questions and answers actually again is how should we gauge response to treatment? Traditionally in the randomized controlled trials, we look at percentage of body weight change, which is one way, but again, we need to look further than that. And again, the ATTAIN-1 trial does do that because we're going to look at other cardiometabolic responses that people see as well. So with the 5.5 milligram dose on average, minus 7.8% reduction in body weight, 9.3 with the 9 milligram, and 12.4 milligrams with the 17.2 milligram dose on average in the efficacy estimate. So again, just represented in graph form. And we see this graph with every treatment. And I think actually this is really important to discuss with our patients. When we apply an intervention, we support people to not have adverse effects. We will see an initial response period, and then gradually over time, we will see a stabilization as they meet an equilibrium, depending on the efficacy of the treatment that they're exposed to. And when they stabilize, weight will stop changing. The ongoing role of the medication now is to maintain that reduction in weight and improvement in health. People, and one of the misconceptions, again, somebody asking in the Q&A about misconceptions, one of the misconceptions is that these are quick fixes, shortcuts, that they will deliver somebody to a lower weight and then can be stopped. People will need to continue these treatments long-term to maintain the benefits. And we know the benefits of a 12.4% body weight reduction can be very, very significant to our patients' health and their risk of future health issues. If we break it down into kind of different responses, greater than 5%, we're seeing 77% of people. And again, it doesn't, I have been involved in obesity medicine for more than, 10 or 15 years. 10 years ago, we were aghast at a 5% body weight change. 5 years ago, we were delighted with a 10% body weight change. Now we're seeing 15, 20 more percentage of body weight change. And I suppose I can never remember, was it Superman or Spider-Man or who said it, with great responsibility or with great power comes great responsibility. We now have increasingly more powerful tools at our disposal to support our patients. And that's why we need to use these appropriately. But again, in ATTAIN-1, we're seeing there 40% of people nearly losing more than 15% of their body weight, which can be transformative for health. So significant response in our patients. A lot is made of body composition and DEXA. And again, this is important for regulatory approval of medications. I think we need to bear in mind when we see some of these percentages thrown around, DEXA looking at, change. I suppose visceral fat reduction for me is probably one of the most important factors we will look at. And this we're seeing on the highest dose, more than 34% body or visceral fat reduction, 25% total fat mass reduction, which is going to be very impactful for health. Lean mass, again, bearing in mind that lean mass is not just skeletal muscle, it also incorporates bone and organ and other non-fatty tissue as well. So again, but only 8% reduction. And again, we have studies from other obesity medications comparing, the change in body composition. And we're not seeing a disproportionate reduction in muscle mass with these treatments. It's similar to if somebody is engaged with bariatric surgery or with nutrition and movement. Anything that causes weight loss is going to cause some muscle mass reduction. And in general, with obesity pharmacotherapy, we know that our patients' function is preserved and their health is improved despite some changes in muscle mass. But important, we keep an eye. Again, going beyond percentage of body weight, looking at, what are our targets of treatment? Is our targets of treatment a body mass index, a percentage of weight change? Is it an ideal weight? We don't have a specific biomarker of adiposopathy. So we're using these surrogate markers. We are seeing, is it improvements in somebody's baseline cardiometabolic status, improvements in their obesity complications? So we're seeing blood pressure, cholesterol, A1C, we're seeing CRP. We know obesity is a chronic systemic inflammatory condition. So again, we're seeing improvements in inflammation, we're seeing improvements in lipids, waist circumference, that visceral adiposity that we saw on the previous DEXA slide, 34% reduction in visceral adiposity. So that's why we're seeing these very significant changes in waist circumference. So moving beyond just numbers on the scales, focusing on more health markers for our patients, to gauge response. As far as safety of treatment, we have another poll question. I'm not sure will people be able to answer this time, but
I'm here with you to help you with this. I'm sorry for the interruption. I'm just want to share this with the audience. So if you may allow me, doctors, of course, if we press next, audience, now you have the access to answer the question. So please, doctor, can you ask the question?
Perfect. Sorry, that was my fault then on the previous one. I didn't move beyond the slide.
No worries.
In the ATTAIN-1 trial, what proportion of patients discontinued Foundayo due to adverse reactions? Is it under 10%, 10 to 20%, or over 20%?
Okay, so we'll give the audience here like 30 seconds. You can answer now, and we can review the answers after, and you can give us your insights, doctor.
Excellent. And again, I suppose, with all treatments, there are adverse reactions. I think personally in Ireland, I think we're getting better and better at kind of counseling our patients, advising our patients, titrating medications in order to reduce, because most of these adverse reactions that we will see are predominantly going to be mild to moderate gastrointestinal issues, particularly during initiation and dose titration. We should not tolerate our patients having these adverse reactions. In obesity, traditionally, people will tolerate a lot, and they shouldn't. We should be avoiding side effects for our patients. So we've given people a chance to respond. So we can see, so 50.9% of people saying under 10%, 41.7% of people saying 10 to 20%, and much lesser saying over 20%. So I think, to that point, we have a slide coming up, but so we'll keep you in suspense for a minute as far as the answer, but I think you can, the majority of people were very correct. We have a very learned audience here of guests. So as we said, these mild to moderate transient gastrointestinal issues, nausea, constipation, dyspepsia, rarely kind of vomiting, and we can see kind of, with the placebo group, we are seeing some gastrointestinal issues as well. But in my patients, I suppose it's counseling people on patterns of eating, food choices. Ourselves, sometimes it is our fault if people are experiencing issues. We may be titrating medication too quickly or not listening to our patients. But the reassuring fact is that despite these mild to moderate issues at the start, they don't tend to be preserved, and they don't tend to affect people continuing with treatment. Again, less common things that people will see with the medication. I think, again, in any of these slides on adverse reactions to treatment, we also need to consider, you will see a lot online about some of the adverse reactions of medications may actually be the adverse reaction of weight loss, feeling cold, telogen effluvium, thinning of the hair, which we see with bariatric surgery, we see with weight loss for many reasons. So again, thinking about the adverse reaction to a medication versus changes from weight loss. So if we look at the kind of composite of all the different treatments, it is actually less than 10% discontinuation rate if we group all the different doses together. With the 17.2%, it was 10.3%. So maybe just on that border, but lesser with the lower doses. So the majority of people getting that one correct in the poll, which is fantastic. As far as contraindications, again, nothing new here compared to our knowledge of other incretin therapies. Contraindicated with a personal history of medullary thyroid cancer or multiple endocrine neoplasia type 2, again, based on preclinical studies in rodents. Again, lots of reassuring data as far as what in human using these medications, but still a contraindication and a warning. Obviously, previous hypersensitivity to one of these medications may be contraindication too. We generally avoid these medications in somebody who is pregnant or breastfeeding. If somebody is considering pregnancy, we need to bear that in mind. Contraception is important if our patient is at risk of pregnancy. Rather than the contraindication, perhaps caution and maybe using this medication in a specialist setting or with an expert prescriber. If somebody has a history of pancreatitis, who has kind of active gallstones, being aware of people with, comorbid, significant gastrointestinal issues in how we apply these treatments. If somebody is on insulin or sulfonylureas, being aware of the risk of hypoglycemia in conjunction with those medications. If they're not, we're not going to see hypoglycemia with these medications. If somebody has symptomatic gallstones, and anything that's going to cause weight change potentially could exacerbate those gallstones. And again, we see that in the clinical trials in people developing gallbladder disease, with any weight management strategy. As far as drug interactions, things that can affect Foundeo, the strong CYP3A4 inhibitors and inducers in the liver can potentially affect levels of Foundeo. Probably in general practice or in family medicine, the one that might be most significant thing that can affect Foundeo will be simvastatin, or that Foundeo can affect is simvastatin, can increase twofold levels of simvastatin. But if somebody's on a lower dose of simvastatin, may not be relevant. If they're on higher doses, may be more significant. Again, we mentioned if somebody's on insulin or sulfonylurea, an awareness about potential risk of hypoglycemia. With contraception, again, it isn't in any guidelines, but generally I will suggest a patient doing a pregnancy test before starting on a medication and ensuring that they're not pregnant, and making sure that we have discussed contraception. And, if somebody does have a plan to become pregnant in the future, the washout period of these medications prior to trying to conceive. Again, for other medications like Mounjaro, the advice would be that somebody, when they start on medication first, that they would use non-hormonal or the non-oral contraceptive means for at least a month after starting and a month after each dose escalation. Just because of the potential change in absorption of the oral contraceptive pill because of delay in gastric emptying. So I suppose starting our patients, we know, and again, this mirrors what we see in the clinical trials, initiating 0.8 milligrams, 2.5 milligrams, and then our maintenance doses potentially 5.5 milligrams, 9, 14.5, and 17.2 milligrams being the maximum dose, at least 30 days at each dose level before increasing further. In my practice, if somebody is having gastrointestinal issues, I will not increase until they have settled. If we go up and somebody develops issues, if it's more significant, we may go back down to a lower dose until kind of things stabilize. Again, our patients shouldn't have to live with significant gastrointestinal issues, because that will affect adherence long term, and these are treatments people will need potentially for the rest of their life, or certainly it won't be this treatment, but it will be a treatment. So again, just to summarize, this is a once a day, can be taken at any time with no restrictions, significant body weight change in our patients. If somebody misses a dose, they take the next dose as soon as possible, and they don't double it, and not to take more than 1 tablet per day swallowed. We don't chew it or crush it. So just kind of general advice. I suppose this is probably what I spend most of my day talking to people about: eating small and often, prioritizing protein for our muscle mass, fiber for our gut, being careful with kind of spicy foods, fizzy drinks, coffee, alcohol, anything that can increase stomach acid, potentially can increase acid reflux, heartburn, burping, belching for our patients. For me, I suppose eating late at night is also a very big one. If my patient eats their main meal of the day after 7 p.m. because of delaying gastric emptying, they may get more issues with reflux and heartburn. Again, being mindful when we are eating and not distracted, that we are focused, because some people may miss those kind of biological fullness cues, and then 30 minutes or 1 hour after eating, they may feel quite uncomfortable, particularly at the start when they are getting used to this new appetite system. Making sure that we're prioritizing fluid intake to avoid constipation, stay hydrated, particularly if people are kind of feeling some of the mild to moderate gastrointestinal issues. Again, what's not on this, I suppose, would be resistance physical activity to protect our muscle mass for our health and well-being. And that is going to be kind of really important. And I suppose really for me, I'm increasingly thinking about health change interventions and weight change interventions. And these medications are both health change and weight change, but things like, focusing on sleep and stress and nutrition and movement, they are very much health change. For some people, they may change weight, but they are vital. in conjunction with the treatment. So again, I'd be making people aware of adverse reactions to kind of watch out for, and then listening to our patients around kind of the issues they're encountering. And most people, if they are focused on healthy eating, physical activity, they will tolerate these medications very well. They may be more challenged if they're out of their normal routine, traveling in an airport, if they're going out for a nice dinner. So just an awareness of different things that can affect their gastrointestinal tract. So we're seeing kind of significant sustained weight reduction, improvement in cardiometabolic parameters, a safety profile that aligns with other GLP-1 medications, once a day tablet, potentially removing some of those kind of burdens, the injection burden, the storage and refrigeration burden for our patients. So the more tools we have at our disposal to treat the chronic disease of obesity, for me, that it is fantastic, and we should be talking about all these different options with our patients. So I'll bring Dr. Al-Mamani back in as well, just to see if he has any kind of comments or thoughts on what was discussed there with Foundeo, or if there's maybe any questions from the Q&A that have come in that will be important or relevant to address.
Thank you ever so much, Dr. Michael. It's an insightful talk. There's something I'd like you to elaborate more on when we talk about the selective agonism. This is something that a lot of people involved in the management of obesity are aware of, but maybe for our newly joining audience, they're not familiar with that concept. And what does that mean in comparison to previously available GLP-1s analogs, please?
Yeah, so I suppose how it activates GLP-1 receptor and gives us those kind of beneficial response as far as appetite regulation, weight regulation. And again, we know there are GLP-1 receptors kind of throughout the body, and I suppose trying to get benefits for our patients without having kind of adverse effects. Sorry, is that what you're referring to?
Yes. Because in your slide, you talked about the activation of the GLP, and then there's the cyclic AMP pathway and the arrestin pathway. If you could just elaborate more.
Yeah, I suppose just different ways of activating the GLP-1 receptor. So again, I suppose this molecule being a non-peptide molecule and how it activates the receptor compared to previous peptides. And I suppose being a non-peptide, I suppose better absorbed through the stomach, so which is very advantageous. We don't have to give really high doses of the medication to get it into the system and across the blood-brain barrier.
True. Do you mind if we go through some of the Q&As? So
Absolutely,
some of them are related to the UAE, some of them are general ones. So there's a question about using it in adolescents at the age of 16. I suppose that's a straightforward one.
Yeah, the ATTAIN trial looks at over 18, so it's not in the licensing at the moment. But again, traditionally with these medications, we will see a safety, efficacy, clinical use in adults, and then kind of over time, we will see further trials and data looking at adolescents and at a lower age. So I suppose the licensing covers over 18. We suppose we need more data as far as using in adolescents, so it wouldn't be currently, but we do have other options available for adolescent patients, probably in injectable form.
Agree. And then there's a question about its use in pancreatitis. Is it an absolute contraindication or a relative one?
So relative contraindication with caution. Again, I suppose it's looking at what was potentially the trigger for pancreatitis. Did somebody have gallstone pancreatitis? Have they now had a cholecystectomy? Did they have de novo pancreatitis? Was there a specific cause? Even with, I suppose, gallstone pancreatitis, there is still a recurrence rate after somebody's had a cholecystectomy, but it's quite low. But kind of, it is very much individualized risk-benefit analysis for our patients. But again, with kind of other incretin therapies, we're seeing reassuring data as far as kind of long-term risks of pancreatitis. So what we don't have is good clinical data on people with a previous history of pancreatitis, because they are excluded from the clinical trials. So again, I suppose that's where, clinical judgment, risk-benefit analysis, what's the potential benefit to a person's health from this treatment versus the risk? And I suppose we don't have good data on that at the moment, but it's a case-by-case, expert-led decision.
I would agree. I mean, I'm not sure about you, but we have used it for individuals with a past history of gallstone pancreatitis who've had their gallbladder removed. And then obviously we need to be cautious with the dose escalation and be having fully informative discussion with the patient.
Yeah, and I think it's one of the confusing. A lot of people think it's an absolute contraindication. It's not. It's relative. But I suppose the counselling, the communication is very important as far as conveying risk to our patients and our kind of, again, I suppose the lack of data, but, and think about kind of alternative treatments for our patients too. But I think it is, hopefully with time, we will get more and more data on use in that setting. But certainly I would personally have patients who've had a history of gallstone pancreatitis who we do treat, but we do go gradually and very cautiously with them.
And then I think this is related to the same thing. It says, if the patient has a mild elevation of amylase, is it an absolute reason not to start the GLP? And
No,
is it routine to screen them?
No, so we don't. It's not routine to screen for those. And I think without clinical symptoms, I'm not convinced an amylase or a lipase are helpful. They're not good screening, and we don't use them to observe these treatments. We know with other incretin therapies, GLP-1 GIPs, normal levels of amylase and lipase are slightly elevated. So if we are checking this, we may be falsely concerned. There's no good evidence for kind of monitoring, for the need for any blood test to monitor the medication per se. We will monitor our patients' comorbid conditions. We will potentially continue to screen them for metabolic dysfunction associated steatotic liver disease and diabetes and health complications and monitor their health, but specifically not for these medications. So we don't routinely check amylase, lipase. I suppose, you as a surgeon will be aware with pancreatitis, you don't wonder if you have a touch of pancreatitis. My patients, if they have pancreatitis, they're on the way to the hospital. So it's not, if I'm wondering, do I have pancreatitis? You probably don't have pancreatitis because you'll be in hospital, with severe symptoms. So we don't monitor or screen. Other things that I'm often asked would be about kind of routine multivitamin kind of supplementation. And again, it's not in any of the guidelines, but depending on our patient, depending on their baseline nutrition, depending on what medical comorbidities or if they have malabsorptive issues, again, potentially involving dietitian. We know people living with obesity are at higher risk of vitamin and mineral deficiency, vitamin D, vitamin B12. So an awareness of that, but we're not routinely monitoring these things. And again, I suppose the obesity pharmacotherapy are not malabsorptive interventions. So it's not like somebody who's having a bypass or, that might change their absorption of nutrients. We're just, we're treating kind of appetite and weight regulation in the subconscious brain.
True. And I mean, to this matter, only yesterday, the International Federation for the Surgery of Obesity have published their recommendation regarding the nutritional supplements for those people taking pharmacotherapy with a past history of bariatric surgery. I would agree with you. I think part of any program treating these individuals should incorporate a multivitamin supplement, because I always tell my patients we're inducing a clinically controlled malnutrition in a way because we're stopping them from eating, and it's important to supplement them.
Yeah, I think it's also for me, I suppose, if their portion size, if the amount that they're eating is reducing, I suppose it really then is important that what they are eating is the best fuel for their body, that they are getting their protein, they are getting their fiber. They can't waste fullness on less nutritionally valuable foods. There's actually a really interesting question there I just saw pop up. In real world practice, what are the most common reasons for treatment failure with modern weight management? So I'm going to immediately jump in because this is one of my big trigger words, this word failure.
I knew it. I knew it.
Yeah, so I'm very predictable. I suppose we don't think about somebody failing a statin.
Michael, please don't take it this way. You're trying to send a new message here. It's not failure.
No, but what I'm thinking, so I think about response to treatment. So because it's not within a person's control. So when I meet somebody and I'm initiating a treatment, I tell them, we have no way of predicting how somebody's going to respond, who will respond. If somebody has a first-degree relative that has had a good response to a particular treatment, I think that may be predictive, but blood tests, genetic tests, questionnaires. We haven't a way of I suppose, predicting. So we apply the intervention, we support people to not have side effects and maximize their health, and we see the response. And I suppose, traditionally, we will think about, response to treatment, but it's not failure or success because it's not within the person's control. We don't think of people failing chemotherapy for cancer. They respond or they don't respond, but it's not within their control. The challenge with weight and obesity is people feel it's their fault, their responsibility, their own, within their control and power. And for me, people do not fail treatment. The treatment fails the person if it's not the right treatment for them. So potentially, if somebody goes on a treatment and is not a responder, and we see non-responders with all treatments, and we even see it rarely with bariatric surgery, or varying levels of response. So over time, I suppose this is the benefit of having many different interventions, and this is chronic disease management in its purest form. We apply an intervention, we see how somebody responds, and if they don't respond through no fault of their own, we change the treatment, we change the dose. Maybe we escalate to bariatric surgery if somebody's regaining weight after bariatric surgery. Maybe we consider medication, but treatment is for life, but the treatment will change.
And I think this is one of the things that we're trying to hammer home. It's only now that we started understanding some of the pathways for this condition. We're targeting 1, 2, possibly 3, 4 pathways, but there'll be other pathways to be discovered in the future. And as you correctly said, it's the treatment that failed rather than the individual. And unless this mindset changes, this is where people struggle to lay the grounds when talking with patients when they come to clinic. And as you said, look, we're going to give you the treatment. We're not going to compare your story to anyone else's story. We'll see how you respond and take it from there. I mean, someone else has asked about the thyroid function screening. I think you can follow up with that.
Yeah, I suppose in our assessment of somebody living with obesity, again, we may do routine bloods to see if there's any contributing kind of factors, while also screening for diabetes and other metabolic diseases. We love to blame the poor old thyroid for all the world's problems, but again, most of my patients, it will have been checked and it will be normal, or they will be treated for it. And once it is normal, then it's eliminated as a cause. Important though, in our patients on thyroid replacement hormone, if their weight changes significantly, then the dose requirement for the thyroid hormone might reduce.
Sure.
Similarly, if our patients are on antihypertensives and their weight changes significantly, now they may not require. So reassessing their ongoing kind of medications and needs is very important. There's a really good question here that came in that I'm really interested to hear your opinion on, Dr. Amamani. In what is your approach to combining obesity medications, prior to bariatric surgery or as a bridge? Is that something that you kind of do in practice, or what's your experience?
So we don't have a huge experience in using obesity management medications preoperatively, purely because a lot of the patients we see will have their surgery covered by insurance, whereas their medication will not. So it's a cost issue more than anything. However, we do have extensive experience in using it in patients who've had surgery and their weight had come back. In fact, we are steering away from offering revisional surgery, and we go first for medications and take it from there. Should they not respond to the medications, this is when we offer revisional surgery, because as you know best, the outcome from revisional bariatric surgery is not much different than giving them an injectable, for example. And this is our experience. What's quite interesting now with the orals is to see how the bypass, weight recurrent, and the sleeve weight recurrent will behave.
Yeah, and even I suppose in bypass, we probably need more clinical data as far as absorption. If it's absorptiometry through the stomach and somebody has had a bypass, again, kind of what impact will that have, or a sleeve as well. So I suppose in somebody post-bariatric surgery, again, we probably need more data of use of oral medications. We may consider maybe injectable medications in that context until we get more information. But again, coming back to the more treatment options we have for our patients and discussing all the treatment options and figure out what's the right treatment for the right person at the right time. And potentially the right treatment is not the most efficacious treatment. It might be the treatment that's most acceptable to the patient, most accessible to the patient, most affordable to the patient, most convenient to the patient, most tolerated. So, it's, and on that, to that vein as well, we're not striving in my practice. I don't have a target dose of medication. I don't have a target weight for somebody. We apply the treatment, we see how they tolerate it. We might look at the maximum, affordable dose, the maximum tolerated dose, the minimum effective dose, and we're constantly talking to our patients. There is this idea potentially on social media and online that if somebody's on a very high dose of medication, they can then drop down to a low dose for maintenance, which again is not what we see in the kind of Surmont maintain trials and the different maintain trials. If somebody has gone up the ladder to a very effective treatment, they will need to maintain that treatment to maintain the benefits, as we see with other chronic diseases. So just important kind of, because these discussions are going on potentially outside of the medical sphere. So it's important that we're aware of our patients talking about these things online.
I mean, it's interesting times, because I think the conversation has completely gone outside the clinics when it comes to this condition. I used to remember when we used to beg patients to consider medication, whereas now it's the other way around. They walk in, they've done their research, and he said, I've read about this, I want this, I want this, I want this. And it's great. It's great. It's great. I think our time is coming to an end. I agree. Our time is coming to an end. Just one quick note, because someone asked about the availability of the drug. Foundayo is currently available in the United Arab Emirates. When it comes to the cost, I would recommend that they discuss it with their team. From my side, I'm most grateful for the opportunity to be amongst you here today. And I'll pass it on to you, Michael, to conclude this session, please.
Well, thank you, doctors. Sure, doctor.
Thanks again for the opportunity. Go for it. No, I just say thank you for the opportunity to chat, and really enjoyed the discussions. So good luck with the rest of the learnings.
Thank you so much, Dr. Hazem and Dr. Michael. We really appreciate your appearance for today, and we've had a fun, amazing sessions for today, including this one. What a remarkable first day it has been. A sincere thank you to all of our speakers, moderators, and sponsors whose generosity and expertise made today's session so enriching. And of course, to each one of you joining us from across the globe, your engagement, your questions, and your presence is what makes the conference truly special. So we hope to see you tomorrow, as tomorrow promises to be equally stimulating, with deep dives into neurology, cardiovascular medicine, AI in clinical practice, and much more. Please rest well, and we look forward to welcoming you back for day 2 of the RCP. Have a great day, and see you tomorrow. Bye-bye.